My name is Pete Rettler. I'm the campus dean, so welcome to Moraine Park. We partnered this year with several agencies, Elevate, Washington, Ozaukee County Public Health, Aurora, and Froedtert to put on this series. We also we have subs out there from Cousin Subs, and Dunn Brothers Coffee's got some coffee and hot chocolate, so please enjoy that. Restrooms, if you walk right out the door over here, take a right and a quick right, there's a men's and women's room right there. So without further ado, I'm going to introduce tonight's facilitators, Ashley Clausen from Washington County Public Health.
All right, thank you, Pete. So I am just going to be facilitating tonight. So first things is we just have a pre and post quiz for you. So this is a QR code. If you have a phone and able to scan the QR code, it's just going to ask you just a couple questions. If you could just answer those for us, and then it'll be the same questions again at the end of our presentations tonight. So I'll just give you a few minutes to go ahead and do that quiz, and then we'll get started. Okay, I hope that was enough time. So we're going to dive right in. We have 4 people who will be speaking tonight. So our first speaker is Ashley Thousand, who is a licensed clinical social worker for Froedtert, who specializes in AODA. Then after her, we're going to have John Grappen-Gieser. I said it right, okay. Who is from PSG. And then you get to hear my voice again, as I will be speaking on behalf of the health department. And then lastly, we will have Lisa Hennon, who is a participant in drug treatment court. So those are going to be our 4 speakers tonight. We will do a few questions in between each speaker if we have time, and then we'll take questions also at the end. So if you're someone like me who forgets your question by the end of the night, you can go ahead and raise your hand after the presentation is done for that speaker, and then I will come around and hand the microphone to you. I just ask when you have the microphone, you hold it pretty close to your lips so that way it can pick up the question. But if we don't have any questions right off the bat, we're going to get started with Ashley.
All right. Okay, so can you hear me? Is it loud enough? Okay. I'm Ashley Thousand. I am a social worker on the inpatient hospital in the main campus in Wauwatosa. My role was developed because we had such a high number of patients that were being admitted with substance use, but specifically with opioid use disorder, and there was really nobody to kind of help those people. And so I'm excited today. I'm really passionate about this, and I'm excited to kind of talk about like what is a substance use disorder and why do they occur. So some just basics of like fentanyl. I believe like it's already kind of been went over in the past during this lecture series, but I just wanted to make sure that everyone was on the same page. So it's a potent synthetic opiate. It's currently approved by the FDA. It's approved to treat moderate to severe pain. Unfortunately, it's also created and distributed illicitly, like in the community. It is up to 100 times more potent than morphine and 50 times more potent than heroin. It has a shorter half-life than most other opioids, causing the high to fade more quickly. It binds to the brain's opioid receptors, specifically in areas that control pain and emotions. So the high potency of fentanyl greatly increases risk of overdose, especially if a person who uses drugs is unaware that a powder or pill contains it. They often can underestimate how much, or the dose of opioids that they're taking, which results in the overdose. We're seeing this a lot in cocaine that's being cut with fentanyl and like pressed or fake pills that are being sold on the streets. Synthetic opiates, including fentanyl, are now the most common drugs involved in drug overdose deaths in the United States. In 2017, 59% of opioid-related deaths were related to fentanyl compared to 14.3% in 2010. I would estimate that in current days, that's even a higher percentage. So what is substance use disorder? I have a whole bunch of definitions. But in summary, substance use disorders are defined as a treatable chronic disease that results in uncontrollable recurrent use of alcohol and/or other drugs, resulting in significant functional impairment and/or extensive negative consequences. So all of the different organizations kind of have their own definition, but they all basically say the same thing. So what is a substance use disorder? So this comes from the DSM-5, which is kind of the holy grail in psychiatry of like diagnosing. It goes through all different substances and gives criteria, but they're all pretty much the same basic ones. So I'm going to run through all of them. If you have any questions at the end, let me know, but they're pretty self-explanatory. So first one is taking the substance in larger amounts or for longer than you're meant to. Wanting to cut down or stop using the substance but not being able to. Spending a lot of time getting, using, or recovering from the use of the substance. Cravings and urges to use the substance. Not managing to do what you should at work, home, or school because of substance use. Continuing to use even when it causes problems in relationships. Giving up important social, occupational, or recreational activities because of substance use. Using substances again and again, even when it puts you in danger. Continuing to use even when you know you have a physical or psychological problem that could be caused or made worse by your substance use. Needing more of the substance to get the effect that you want, known as tolerance. And development of withdrawal symptoms, which can be relieved by taking more of the substance. The DSM goes even further to kind of classify these into 3 different categories of mild, moderate, or severe. So mild is between 2 and 3 of these criteria, moderate is 4 to 5, and severe is 6 or more of these items. It also goes into like, you can diagnose even further by like classifying things as like early remission, which is from anywhere from 3 to less than 12 months, or sustained remission, which is more than a year of complete abstinence from opiates. So, what leads to substance use disorder and why do only some people develop one? So substance use disorder is common. Over 20 million people in the United States have at least one substance use disorder. The common progression of substance use disorders tend to be experimental use or maybe prescription use, which then moves on to occasional use or misusing your prescriptions, taking more than you're prescribed. Heavy use, which is daily or near daily use. But at that time, there may be minimal negative consequences that you've experienced. And then substance use disorder, which is the loss of control, and then physical and psychological dependence. So there is no one single factor that determines if a person will progress all the way to substance use disorder. Most commonly, it's a combination of factors. So the more risk factors one person has, their chances of developing a substance use disorder increases. So some of the biggest factors include biology, which are the genes that one is born with, and this accounts for about half of a person's risk for developing a substance use disorder. Additionally, if a family member, specifically a first-degree relative, has a substance use disorder, that also increases your risk. Any behavioral health disorders, so an individual with a prior psychiatric disorder also increases the risk of development of a substance use disorder. Typically, an individual will feel that their substance use is helping them cope with their symptoms and kind of potentiates each other. Specifically, ADHD, bipolar, borderline personality disorder, depression, anxiety, and PTSD kind of fall into this category. Environment is a huge one, and it kind of encompasses quite a lot. So this includes like your family unit, your friends, your economic status, any history of like abuse and stress. Specifically, any exposure to traumatic experiences has shown to greatly increase a person's risk of developing a substance use disorder. Age of onset. So early exposure to drugs can greatly increase or influence a person's likelihood of ongoing substance use. Part of this is due to like an underdeveloped frontal lobe, which kind of, I don't want to say encourages, but makes you more likely to engage in risky behaviors. And then mode of ingestion. So there is a significantly increased risk of developing a substance use disorder with IV drug use, with the idea behind that being it's like a more intense high and it becomes more addictive a little bit more quickly. So short-term effects on the brain. So this is what we would consider the high of opiates. So lowers inhibitions, provides relaxation, the euphoria that kind of everyone talks about with opiates. Pain relief, sedation, can cause confusion. Kind of more like neurologically, it alters activity in your limbic system, which influences and controls your emotions. It also disrupts your brainstem, which controls basic functions that are critical to life, like your heart rate, breathing, and sleeping, which is why in overdoses, we typically see people will stop breathing. So some of the longer term effects. And so this is kind of going to go more into like the brain's reward system and neural pathways. So opioids affect the brain's reward circuit by flooding it with a chemical messenger known as dopamine. Surges of dopamine in the reward circuit cause the reinforcement of pleasurable but unhealthy activities such as the drug use. So this leads people to do this behavior over and over again. The surge of dopamine is what is believed to cause the high or the euphoria associated with the substance use. According to the National Institute on Drug Abuse, large surges of dopamine teach the brain to seek drugs at the expense of other healthier goals and activities. So the brain kind of gets used to these intense surges of dopamine and the instant gratification from it, and it wants to continue that versus other activities like, say, exercise that may be like smaller doses of dopamine over a longer period of time. So eventually the brain will adjust to the excess dopamine, and this reduces the high that the person feels compared to the high that they felt when they first started taking the drug. This is part of tolerance. This is also like the idea of like chasing the dragon or like chasing that high that you first got when you first used, which motivates a lot of continued use. So prolonged drug use changes the brain in ways that make quitting difficult even for those who want to. Repeated use can lead to brain changes that challenge a person's self-control, ability to experience pleasure, and interfere with their ability to resist intense urges to use. So quite literally, the ongoing substance use will change neural pathways and will make things that were once pleasurable, like your favorite food, sex, exercise, anything like that, will make it less pleasurable and make you not want to do it. This is why substance use disorders are considered relapsing disorders. This is a persistent thing that lasts. People in recovery from substance use are at an increased risk for returning to drug use even after years because of this. So how can use lead to a substance use disorder? It's all about how the brain responds to the substances. So the brain will adjust eventually to the excess dopamine by producing fewer neurotransmitters or like things in your brain that can kind of absorb that chemical and the reward associated with it. So when that occurs, the person's ability to experience pleasure from naturally rewarding activities is also reduced. So eventually the person will begin to feel flat, without motivation, lifeless, and or depressed, and unable to enjoy things that used to be pleasurable. The person will need to keep taking substances to experience a normal level of reward. So essentially your brain gets so used to kind of this flooding of dopamine in it and this constant gratification that when you return to a normal level of dopamine, your brain feels that it's in a deficit, and it makes kind of these feelings of like depression and loss of motivation, lack of pleasure emphasized. So this all leads to that over time, most people do not continue to use drugs to feel good, like we mentioned. A lot of times the quality of the high will decrease over time. It's more because they use to feel normal. So how does relapse contribute to continued use? So opioid withdrawal plays a really big role in this. Opioid withdrawal occurs when an individual with physical dependence will abruptly stop or reduce the amount of opiates they're using, and they'll develop withdrawal symptoms. So typical withdrawal looks like low energy, irritability, anxiety, agitation. Insomnia is a really big one. Runny nose, watery eyes, hot and cold sweats, or goose flesh, goose pimples, excessive yawning, extreme muscle ache and pain, abdominal cramping, nausea, vomiting, and diarrhea, anxiety and dysphoria, restlessness and fatigue. Oops, sorry. So a lot of times I'll talk to people and they will tell me that opioid withdrawal feels like the worst flu of their life. They felt like they were going to die. They didn't know when it was going to end. They didn't think it was ever going to end. So even though opioid withdrawal is rarely life-threatening, the severe symptoms that it causes is a motivating factor for individuals to continue their use. So one way to look at this is about 45% of people who use heroin started with an addiction to prescription opiates, according to the American Medical Association. A large percentage of these people did so to avoid the withdrawal associated with stopping their prescription opioids. So untreated opioid withdrawal symptoms will frequently result in relapse to opioid use to avoid withdrawal or end the withdrawal, because reusing opiates during withdrawal will stop the withdrawal symptoms immediately. So let's see. So there are medications that we currently have for opioid use disorder that try to mitigate the risk of this. So the current medications that are most common are buprenorphine or Suboxone or Subutex and methadone. These medications are used to minimize withdrawal symptoms, and they prevent prevent relapse from the unbearable withdrawal symptoms. So this can help move patients into appropriate level of treatment, where they can then choose to stay on these medications or taper off. A lot of times these medications give people hope in their recovery. It kind of gives them control over their withdrawal and over their recovery, and moving forward into like the treatment that then they choose. So I think that's it. Oh no, I got one more. Okay. This is a little bit change of topic, but similarly. A big thing I work on is destigmatizing substance use disorders. So changing language for addiction. So a lot of terms that had been used previously are quite stigmatizing, and give people the wrong impression. So we're trying to change the way we talk about substance use and people who use substances. So instead of words like addict, junkie, druggie, you want to use terms like person with a substance use disorder. Things like alcoholic or oxy-addict would be replaced with things like person with an alcohol use disorder or person with a opioid use disorder. Instead of like former alcoholic or ex-addict, you want to say something like person in recovery. The idea behind this is kind of person-centered. Their drug use or their alcohol use does not define them. It's a disease that they have. Additionally, we have things like clean, dirty drug screen. You want to say negative, positive drug screen. And then things like addiction or addictive disorders. We're moving away from the term addiction to just be substance use disorders. So what are substance use disorders? Substance use disorders are not a moral failing, a character flaw, a willpower problem, hopeless, or untreatable. Substance use disorders are chronic, but they are also treatable medical diseases involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. And that's the last one. Does anyone have any questions?
Thank you. Thank you for the information. I have a question. So you talked about if, someone might be more susceptible to this disorder if they have someone in their family. So I'm curious, what can you do to help people that are in that situation and to not go down the path of using and potentially getting addicted to that? How can you help support family members in that situation?
Yeah, so I think a big part of it is awareness. A lot of people, when I tell them, or when I take a history and they tell me that they have a family member, a parent, or a sibling with a substance use disorder, they're shocked when I tell them that this likely increased their own risk to developing this. So a lot of it is just kind of preventative awareness. And that can also go as far as, the parents I work with, I teach them the same things, like educate your children about this as well. So going forward, they know and they're more aware of this. So yeah, just kind of making awareness that you are at an increased risk for this when you have this factor and being mindful of it. And that, when you have those increased factors, things like experimental use, just trying things a couple of times could quickly slide, where for someone without all those risk factors, it might not. All right, thank you.
Okay, so next I'm going to invite John from PSG up.
You didn't try it again?
No, I'm not going to.
Understandable. I wouldn't want to try that either. Can you guys hear me okay? All right. So my name is Dr. John Groppengieser. I am a psychologist and a director at PSG, Professional Services Group. We are a social services agency that provides outpatient mental health and substance use treatment in a variety of counties in southeastern Wisconsin. We also provide a variety of other programs. We're involved with youth justice, child welfare. We do case management in the mental health and substance use realm. So we really have a lot of exposure to individuals coming from different types of programming. And one thing that I will tell you that is a common thread amongst all of those is that we see substance use disorders with all of the families we work with throughout all programs. It's not just folks coming in for treatment. So this is a really pervasive problem that we're trying to help and manage. We've talked about, obviously, how we get to substance use disorders. So now we're going to talk about what do we do about it. This is a really large topic. I could probably talk for several hours about this. So I'm gonna do my best to condense it into about 15 or 20 minutes, kind of give you the basics around some of the language and some of the things to expect with treatment. And we're gonna start off with just what is substance use treatment? We hear the term substance use treatment, we hear psychotherapy. Are they the same thing? Are they different? So really, psychotherapy, substance use treatment, many of the same elements are going into both. However, there is a difference between mental health psychotherapy and substance use treatment. When we're working with individuals with a substance use disorder, one of the really important things that we need to do is at that initial appointment is get a really good assessment of what is the severity of their substance use. And in addition to that, is there any comorbidity happening? So that big fancy word just means, are there any mental health co-occurring disorders? So we want to get a good idea not only of what is the substance use, how substantial is it, but is there any ongoing mental health concern accompanying that? Because that's going to help us determine what is the proper level of care. And we'll talk about what the different continuum of care looks like in a little bit. In addition to that, we then think about how many individuals out there are struggling with a substance use disorder. And according to the National Institute of Health, we know that approximately 20.3 million adults in the US have a substance use disorder. And roughly 38% of those, so that translates to about 7.7 million, are managing a co-occurring mental health disorder on top of that. It's a really, really large number. And when you dig even deeper, it becomes a little bit more concerning because of that 7.7 million that have co-occurring disorders that probably need some form of intervention or treatment. We know that only 35% of those folks are getting strictly mental health care. So of that 7.7 million, less than half are getting treatment specifically for mental health care, not even getting treatment for their substance use. The percentage of folks getting treatment for just their substance use is only about 4%. That is a minuscule number. So what this sort of highlights for us is that there's really either a lack of utilization. I think those of us who work in the field would argue it's not a lack of utilization, it's more potentially a lack of resources for people to get into treatment. And we'll look at what some of those barriers are in a minute. Dual diagnosis is another thing that comes up a lot. And dual diagnosis basically is an individual who is struggling with a substance use disorder and a mental health concern. And you may have treatment that is more specially and specifically geared towards folks who have those co-occurring disorders versus some treatment that's more geared specifically to substance use. So these are common terms you may see if you're looking for programming, if you're looking at programs' websites and things like that, you may see that they have a dual diagnosis track versus a strictly substance use track. In terms of the access to treatment that I was just talking about, there's a lot of research been done in the past several years around what are the big barriers. One of the biggest barriers is transportation for folks to access treatment. One of the other largest barriers is cost and coverage. So while a lot of individuals may have insurance, when you look at things like deductibles, coinsurance, and copays, it really can restrict access for a lot of individuals because substance use treatment generally requires more dosing, and by that I mean more frequency of treatment. So maybe coming in multiple times a week, maybe going to group and having an individual session or a family session. So now maybe you're being seen 3 and 4 times a week. Those bills can add up really fast, even if you have great insurance coverage. So that is a very, very large barrier. In addition to that, just the access. There's not enough providers. We know in our state in particular, there's not enough mental health and substance abuse providers, period, to meet the need. We can't keep up with graduates coming out of school. There's not enough to meet this need. And that's going to continue to grow as we see that 20.3 million folks in this country are struggling with both mental health and substance use. The last term here that I want to just kind of touch on is harm reduction versus abstinence model. You may hear this talked about in different treatment programs. So an abstinence model, we've moved away from that in a lot of areas. An abstinence model was no use whatsoever. If you're going to be in treatment, you're not going to use, and that's how you're successful. We've moved away from that to much more of a harm reduction model. And what that is we're just looking at making sure the person is safe and meeting them where they're at and continuing to help them work through recovery rather than saying you have to be completely sober, fully in recovery, and that's just how it's going to be. So that's been a big shift probably over the last 30-ish years, but a really important one, I think, in how we're treating these disorders. So when I mentioned the continuum of care, there's a variety of different levels of care for substance use. And you may hear a lot of these terms depending on what programs you're looking at. The thing to kind of remember here is that folks can enter this continuum at any point, and it's going to depend on sort of that initial assessment. So how substantial is the use? How risky is the individual in terms of, again, frequency of use, severity of use, but also looking at things like what kind of co-occurring mental health conditions may exist. So that's going to impact where they maybe start treatment, and that could change over time. They may start at a lower level and then realize I need a higher level, or things aren't going so well in recovery, so they move to that higher level. But the important thing to know here is that it's a continuum, and you can move through those at different rates, and everyone does it at a different, in a different sort of path or pattern. At the top of that continuum would be detoxification services. So this is when an individual, particularly with an opioid use disorder, is really struggling with addiction. They're actively using, they're using pretty heavily, and they need a medically monitored detox program to make sure that they can safely stop using and potentially move to maybe a medication-assisted treatment or something along those lines. So a detoxification service sort of level of treatment is going to be relatively brief, and it's going to be very centered around medical concerns, physical safety. You're not going to get a lot of psychological treatment there. They're really focusing on just making sure you're physically well and safe to move on to the next level of care. Residential care would sort of be your next step down. Residential care is sort of where you would go live at a facility. You stay there 24 hours a day. You may stay for 30 days, you may stay for 60 days. Some places might be 90 days. A lot of that, again, depends on insurance coverage, severity of your use coming in. But residential care is going to include group therapy, individual therapy, family work, medication services, medical monitoring. So it's a really comprehensive treatment for folks that need that sort of almost highest level of care available. Residential care, once you move through that, you move into the outpatient services. Now, outpatient services, there's also a continuum within that. And as you can see, we have partial hospitalization, intensive outpatient, regular outpatient care, and I mentioned medication management as well. So partial hospitalization is also called day treatment, depending on what type of facility you're receiving the treatment in. What that's going to look like is anywhere from 15 to 20 hours of programming a week. So you're going to go to the facility maybe in the morning, you're going to do about 4 to 5 hours of treatment, maybe do some group, individual work, maybe a family session. Then you're going to go home at night, but you're going to go back the next day. And you might go 3 to 4 days a week, again, hitting that roughly 20 hours of treatment. But you're staying in your own home. So it's sort of a step down from that residential level of care. Then you have the intensive outpatient program level. This is similar to day treatment in that it's going to be about 3 hours a day. So you're looking at roughly 10 to 15 hours of treatment a week, maybe 3 to 4 hours of group, an individual session 3 days a week. So you're still getting a pretty robust level of treatment, but you're moving down through that continuum. And again, you're going home at night, you're living your life, maybe you're going to work in between treatment, things like that. And then outpatient care is sort of that last rung, and that can be widely varied depending on the person. So it's going to be anything that's 9 hours of treatment per week or less. So this could be someone who is coming to 2 or 3 groups a week, plus doing individual and family. They're technically in the same level of care that maybe someone who's only going once a week to individual and once a week to group. Same level of care, but obviously very different needs for those individuals. So the spectrum is pretty wide within that outpatient care realm. One thing that I don't have on a slide, but I do want to stress, is just the idea that moving through these continuums of care and moving through treatment doesn't necessarily move quickly. You know, many of these things, like I mentioned, residential, it's 30 days, maybe 60 days, 90 if you're really lucky. Partial hospitalizations, maybe a month. IOP can be anywhere from a month to 2 months, sometimes extending a little bit longer depending on how you're doing. Outpatient care could go on for several months. So really the window of treatment is going to be individualized by the person, but it could be anywhere from, say, 6 months, 7 months, to up to a year, year and a half to really work all the way through this continuum. I realize that sounds like a lot of time, but from a recovery standpoint, it's really important that we have that expectation that recovery is going to take a long time to move through these stages of treatment, but also remembering at different points in recovery, you may need to bump back into one of these higher levels of care and move back through it a bit. Evidence-based treatment, I'm just going to touch on this briefly. As you think about treatment programs and looking for treatments for substance use, it's important to look for evidence-based approaches. And so what does that mean? Basically, evidence-based treatments are different treatment modalities and treatment techniques or programs that have gone through rigorous research, they've been studied at length, and they have consistently shown positive outcomes related to recovery and sobriety. And so there's a variety of different things. It's not like there's one specific thing or 2 things that we tend to look for. There are a lot of evidence-based treatments, but it's also important that you go into a program maybe asking some of those questions, like what kind of evidence-based treatments or practices do you use? And there are different resource databases out there. I gave an example of one from SAMHSA in the slide, and you can go to these databases and literally search cocaine use, opiate use, and it'll give you a list of all the different evidence-based treatments that are available. It's a really nice resource to have. In addition to that, you're often going to hear things like CBT, cognitive behavioral treatment or cognitive behavioral therapy. DBT is another common one you might see from an evidence-based approach. That's dialectical behavior therapy. CBT in particular has a lot of research around substance use specifically, as well as substance use and mental health. So that's going to be a common ingredient in a lot of treatment approaches. Basically, what you're working there with cognitive behavioral therapy is you're looking at how your thoughts, your emotions, and your behaviors work together and intermingle to either create some difficulties or to help you move through recovery. DBT is an approach that's used predominantly with mental health, but in recent years we've seen, particularly in dual diagnosis programs, there's been more of an emphasis on utilization of DBT because it can be really helpful working with individuals with certain types of mental health diagnoses. The last piece to evidence-based treatment is a lot of the programs rely heavily on a lot of behavioral aspects. So think about things like positive reinforcement, negative reinforcement. We call that contingency management, but also looking at increased structure. Oftentimes, a lot of treatment programs put a lot of focus on how do you structure your day? How do you keep occupied? It's because these things have been shown to be really effective with long-term recovery. Medication services. So the previous presenter touched on a few of these, and I'm going to just kind of reiterate some of these as well. The term MAT is one you will commonly hear, particularly around opioids, medication-assisted treatment. So there's a few sort of predominant medications that are helpful with us in managing substance use disorder. And specifically, these MAT medications aim to reduce and manage withdrawal symptoms while also managing cravings. And methadone is one of the older ones. It's been around for a while. Suboxone and Subutex, I don't want to say are newer. Subutex is newer. Suboxone's probably been around for a good 30 years. It still feels to me like it's newer. I guess that kind of ages me. But those are great medications. Buprenorphine is the generic term. And again, they're less, methadone can be a little bit more impairing. Suboxone isn't nearly as impairing as methadone can be. Subutex is even better because it's an injectable, so there's no concern of abuse, there's no concern of diversion of the medication, or in other words, people selling it or trading it for things. So those are really, really useful medications. Vivitrol is one that's gained a lot of traction in recent years. Vivitrol is an injection. It's naltrexone, which is also used for alcohol treatment. And Vivitrol is an injectable medication that is given, and instead of managing withdrawal, it's more focused on cravings, but it also blocks the receptors that opioids try to attach to when you use opiates. So those have all become really, really popular and very effective in helping with recovery and opioid use. In addition to that, I just mentioned other psychotropic medication in general, because like we talked about earlier, often there are co-occurring mental health concerns, and so often there's other psychotropic medication that will be used in conjunction with treatment, sometimes in conjunction with MAT treatment. There's a few caveats to that. Obviously, some typical antidepressants, mood stabilizers, anti-anxiety medication is all pretty common. There are certain medications, though, that are contraindicated from a treatment standpoint because they may be medications that could be abused. They may also have bad or very dangerous interactions with opioids. Benzodiazepines, Valium, Xanax, those types of medications are often avoided at all costs with someone with an opioid use disorder, particularly if they're utilizing some form of MAT. So those are the things just to be aware of, but also knowing that psychotropic medication does play a pretty important role. I'm going to talk just briefly about community-based interventions, and I'm going to start it by saying the treatment stuff is all really great and really helpful and necessary. You think about those initial treatment things that I touched on sort of as, I don't want to say the acute phase, because it's not just for the acute phase, but it's for when you're trying to really get your substance use disorder under control and managed in a good spot so you can continue with recovery. These community-based interventions, these, in my experience, these are some of the most important things in sustained recovery for people. So often they aren't thought about as a form of treatment, I don't think, because it's not going to see a therapist in an office or going to see a doctor. But these are things that can really sustain recovery and lead to substantial long-term success. And so when we're talking about here is things like case management. And I give you some examples of some different types of case management that's out there, just some different terms. But when you think about that, it's case management programming is where you're connected with someone who's your social worker or case manager. They're helping connect you to appointments. They're checking up on you. Maybe they're helping you with day-to-day things like, oh, you got a transportation issue? Let me help you out with that to get you to that appointment. You're having trouble with applying for some sort of benefit? Let me walk you through that. Employment assistance, like all of these things that are so important for sustained living outside of substance use case management and these community-based supports can be really crucial for. Another one is peer support specialists. So in our state, we certify peer support specialists, and these are individuals that go through a course, they pass an exam with the state to become certified, and they are individuals who have lived experience with mental health and substance use. And then they can work with individuals who may be at a different place in recovery, and they're someone who can say, like, I've been there. Here's what I did. Here's what my experience was like. And for someone who's in that, that's a much more powerful person than, say, going to a therapist who maybe has never been there, doesn't understand completely. This person can go to that place with them and really meet them where they're at and truly understand. In addition to that, we have support groups, Narcotics Anonymous, Alcoholics Anonymous, Smart Recovery. COVID did some wonderful things in terms of virtual groups popping up. I was in drug court in Milwaukee before I came here, and we had someone who was kind of in crisis today, and one of the things that we were able to connect them with was go to a virtual meeting, because they couldn't get to an actual meeting, and we were able to get them that resource. So support groups can be a really great thing just for, again, that ongoing recovery and managing of the substance use disorder. And then I mentioned drug treatment court. We were gonna have drug treatment court tonight. I think they're next time, right? But that's also another great example of a community-based model that's obviously more specifically for individuals involved in the legal system, but really great support. It has a lot of these community-based components like case management, encouragement, utilizing a lot of the same techniques and strategies that treatment does, but in a different way. So those are all really, really helpful things. And I can't stress enough how important these things are for long-term sustained recovery. Okay, that's all I got for you. Anybody have questions?
Did such a good job. No one has
Covered
questions.
everything. Thank you, guys.
Thank you. Okay, so now you get to hear from me. So I'm going to kind of switch topics a little bit and go into harm reduction. So John mentioned this just a little bit in his presentation. And so I am Ashley Clausen. I am a strategist for the Washington Ozaukee Public Health Department. And so I run our substance use coalitions, our Narcan program, things like that. So I really specialize at the health department in substance use. So what is harm reduction? Show of hands here. How many people have heard of harm reduction? Awesome. It's good to hear. So according to the National Harm Reduction Coalition, harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with risky behaviors, so things like drug use. It's also a movement for social justice built on belief in and respect for the rights of people who use drugs. So examples of harm reduction. I really wanted to put this picture up here because I feel like a lot of times when people think of harm reduction, their automatic thoughts is to go into things like Narcan, fentanyl test strips, and they don't think of the other things that have been in practice for years that are also considered harm reduction. So we have things like sunscreen, seatbelts, speed limits, birth control, cigarette filters. So those are all harm reduction practices and harm reduction strategies, right? So seatbelts are used to reduce the consequences if someone were to get into a car accident. That protects you from those potential consequences. Sunscreen to protect you from the sun and that risk of skin cancer. So all of these are different forms of harm reduction, and I always think that that's really important to point out when talking to people about harm reduction. So why use harm reduction strategies? So there was over 100,000 drug overdose deaths in the United States in a 12-month period. So that was actually an increase of almost 30% from the previous year, which was only 78,000 deaths. So we see that that is a huge jump, and we are seeing more overdoses, unfortunately. So what does harm reduction do? So harm reduction plays a significant role in preventing drug-related deaths. It helps offer services to individuals, social services, treatment. It allows an individual to stay alive until they're ready for help. I think that's the big one to point out. And then these strategies are also great for reducing acute life-threatening infections related to drug injection and chronic diseases such as HIV and hepatitis C. So I'm going to touch a little bit about some of the harm reduction strategies that the health department offers. So the first one is the Narcan program. How many of you here knew that the health department hands out Narcan to community members? Okay, that's good. That's a good show of hands. So we do hand out Narcan to community members. It's the nasal spray. And so no questions asked. Anybody in the community can come in, grab some Narcan. We do just a quick little training so that way folks leave and understand what Narcan is, how to properly use it, just some information that goes along with it. So Narcan is a medication that's used to reverse the effects of an opioid overdose. So really emphasis on that opioid part. So I've listed some examples of opioids here. So it doesn't work on things like alcohol, it doesn't work on cocaine, anything that's not an opioid. However, if there is an opioid in that supply, so fentanyl, we're seeing a huge increase of fentanyl in the supply today. So if someone was using cocaine or meth and there was fentanyl in it, Narcan will work for that fentanyl portion of it. So it won't completely work with any other substances besides an opioid, but it will take care of that opioid portion that is in there. So like I said, the health department hands it out for free. We do a little training, and then you're off with Narcan. You can come back as many times as you need to get it. There's no criteria for you to come in and grab it. So just kind of some information about Narcan. So first, there are two kind of laws that I like to mention. So there is a standing order in the state of Wisconsin, which means you do not need a prescription to carry Narcan on you. Anyone can carry it at any time, and you cannot get in trouble for carrying it. You're also covered under the Good Samaritan law. So kind of the same, similar to CPR, you're acting in a good faith. God forbid something were to happen and you're administering Narcan to someone, you are covered under that law. The only time that you can be penalized for that is if someone is on probation or parole. If an officer does show up to the scene, they can arrest you for that. So the Good Samaritan law covers the caller. So if me and my friend goes into an overdose and I call, I am covered under that Good Samaritan law. Unfortunately, again, if an officer arrives, even if I get rid of everything, they can charge the person who is overdosing with whatever's in their system. So a lot of times, unfortunately, we're seeing people are not calling 911 for that sheer fact because they don't want to get themselves or others in trouble. So those are two things that I just like to point out. Yeah.
How to get rid of that piece? Were they not charged with that?
What was that?
Is there anything being put in place right now trying to reverse that where they can't be charged?
Yes, so there are some activists and politicians that are looking into potentially changing that law so that way people don't get in trouble, and then hopefully that allows more people to call 911. So yes, good point. There are people working on changing that, so that way hopefully more people are calling 911. So fentanyl test strips, that's another harm reduction strategy. So we do not currently hand out at the health department. Tony Evers, our governor, decriminalized them actually in April of last year. So there are some places that are getting on board with handing out fentanyl test strips, again, for free to the community. So it is something that I did just want to touch on, especially with the rise of fentanyl that we're seeing. So it's a test strip that allows an individual to test if fentanyl is present in their supply. So that picture kind of shows I always compare it to like a pregnancy test. Lines either appear or don't appear. So one line is a positive result and 2 lines would be a negative result. So it does not test for quantity or anything like that. It just tests to see if it's present. I've also had people ask if it tests for like analogs. So we're seeing a lot of fentanyl being kind of changed, carfentanil, things like that. It depends, truthfully. Most of the time, those analogs do not show up on the fentanyl test strips, but there is a chance that there is other forms of fentanyl in there that would turn it to a positive result. So you can use these test strips to test pretty much almost any substance. So essentially, you just need kind of a tiny, tiny little bit and some water. And essentially, you just swirl the top of that test strip around in that water. And it takes about 2 to 3 minutes for the result to show up. And again, those lines either appear or don't appear, and you have your result. So Washington County actually declared a fentanyl crisis in August of 2022. Our county executive, Josh Showman, went on with Waukesha County as well and declared a fentanyl crisis, as there was 80% of the overdose deaths for Washington County actually had fentanyl involved in it. So that's a huge number, 80%. Almost 100% of the overdose deaths came up with fentanyl as well. So that's just something to highlight as well. When it comes to fentanyl test strips, like I said, DHS, so the Department of Health Services for Wisconsin, is actually working on trying to phase out fentanyl test strips to organizations, to departments, to be able to hand out to communities. So with Narcan, you can actually also go into a pharmacy and buy it. So anyone in this room, correct me if I'm wrong, I don't think you can go into a pharmacy or places like that to buy fentanyl test strips. And I'm looking at you, Morgan and Mary, and if anybody knows that, I don't think they have it out in like pharmacies and places like that for fentanyl test strips. Walgreens? Okay, that's awesome. So Walgreens might. I know you can go on Amazon and order them, so that's also a possibility. But you can walk into a pharmacy and buy Narcan. It can be a little bit pricey, so just keep that in mind. You might want to find places that hand it out for free. Otherwise, too, you can get a prescription for Narcan. So any doctor can write you a prescription. Again, you don't need a prescription. It's not required. But I have heard some places in the area, in regards to pharmacies, do ask for a prescription in order for you to walk out with it. And so just keep that in mind as well. So then resources. So 3 resources I think highly of. So Substance Abuse and Mental Health Services Administration. So that's always a great website to go for any information really around substance abuse and mental health. And so I've put a link on here just for their page on harm reduction if you're interested in knowing more. The Center for Disease Control and Prevention, that's also another great resource if you have questions about substance use, opioid use, harm reduction. And then the National Harm Reduction Coalition. I feel like this one's not prevalent, I don't know what the word is. A lot of people might not know what it is, but it is a national group that really focuses on those principles of harm reduction and trying to educate people on harm reduction and why it is so important to practice harm reduction. So my presentation was pretty short tonight, but if anyone has any questions, I'd love to answer them. Also, again, come to the health department if you need any Narcan. I do have some available tonight if anybody would like to take some home. We have some boxes. Otherwise, you can stop by the health department. We have 2 offices, one in West Bend at the county administration building, and then also a location in Port Washington at the old courthouse downtown Port. That is my information. Feel free again to reach out to me if you have any questions or anything comes up after this presentation. Pete, I see you have a question. I'm going to come back to you so I can hear it.
So I've got a couple questions. So one is, I believe a speaker like week two talked about you don't know if somebody is overdosing, and you give them fentanyl. In like 99.9% of cases, you're not going to harm them by giving them Narcan.
Yes, so that is correct. A lot of the signs and symptoms, if you guys are not aware, so things like someone's breathing, their pulse is low, their body temperature drops, their lips or fingertips may turn blue. So a lot of those signs and symptoms can really be any medical condition. And so people are like, well, how do I know if it's an overdose or if it's another medical condition? Narcan will never harm anybody. So if you don't know why somebody is unconscious or any of those signs and symptoms, feel free to administer Narcan if you have it on you. It just won't work if the person's not overdosing, but it'll never harm somebody. It's safe for pets, kids, anybody can use it. It's a good question.
All right. The next question. So I gotta think what I was going to say. One of the issues with giving someone Narcan is they might come out swinging out of this, but I believe one of our presenters talked about the one night that the spray is basically enough to keep them alive and might not get them to the point that they might be violent. Is that correct?
Yes, so there's multiple forms or ways you can administer Narcan. So the nasal spray is one way to do it. You can also do it intramuscular or intravenous. And so there are sometimes side effects of somebody may come up swinging, or, you know, it's kind of that jolt of adrenaline for somebody. And so it depends really on how much Narcan is given, what substances they're on. But the nasal spray does tend to have kind of that, I don't want to say lesser effect, but that potential for not as someone coming up swinging.
And then the final one, I remember one of the presenters talked about that they were upset that there was hardly any schools. I believe only one school in Washington County was Kettle Moraine Lutheran. They said allowed, or they had Narcan. And, but she said, and I think you confirmed it tonight, that she said, I send my child to school with Narcan in their backpack just because they don't allow. So you could have a college or a school that doesn't allow or doesn't have Narcan available, but you very well could have people carrying Narcan on your premises.
Yes, great question. 100%. If a school or organization or anywhere doesn't carry it and you want to carry it on yourself, you cannot get in trouble for that. Again, you can go ahead and use it on that premise as well. You're covered under that standing order and that Good Samaritan law. So don't be afraid to carry it on you anywhere and use it at any time.
No further questions.
No more questions. Awesome. Oh, yeah.
Oh, geez.
What is the shelf life of Narcan? So if you are carrying it just in case you need it, like how long does it last?
Yes, great question. So the question was the shelf life of Narcan. So it lasts for 3 years. It likes to be kept at room temperature. So lovely Wisconsin, why we had to reschedule. You know, one day it's 20 degrees and the next day it's 90 degrees. So we just recommend not keeping it in your car. It doesn't ruin it if, let's say, you do leave it in your car overnight. Just bring it back to room temperature. It's still going to be effective. It just doesn't like to live long-term outside of room temperature. But the shelf life is 3 years. When it expires, feel free to just throw it away in the trash. It's non-biohazardous, even if you didn't use it, and then you can go and pick up some new Narcan.
Is it more of a statement than a question? Would be suggested about after being Narcan, it's probably best practice to get medical help after that as well, to see if there's any damage done from the actual overdose. Because Narcan's not enough, because later on you can actually go back in withdrawal if it wasn't enough administered to that. So maybe go in the hospital after their overdose, go take your friends or whoever there, just don't keep them in the house, because they could have reversed and go back in withdrawal. Or other medical conditions from that overdose, because your organs and stuff are gonna pay a price for that as well. So just advice.
Yeah, good point. For those of you in the front, if you didn't hear, he just mentioned we always obviously recommend calling 911 and taking someone to a hospital just because you don't know, and they could go back into an overdose. So Narcan has a shorter half-life than most drugs, and so it wears off in about 30 to 60 minutes. And if someone has enough opioids in their system, those opioids can go right back onto the receptor, and they can go back into an overdose. So if 911 isn't called, we always recommend staying with someone for at least 2 hours just to make sure they don't go back into that overdose. But of course, we always wanting to be trying to call 911. But good point, thank you. Any other questions or comments? Okay, so I am going to invite our last speaker up for the night. Lisa is a participant in drug treatment court.
Thank you.
Yes.
If I can reach it, I might have to sit on this chair. Kind of short. Hello, everybody. Can you hear me? My name is Lisa, and I'm just going to share a little bit of my story with my mental health disorders, addiction, and my recovery. So, my name is Lisa, and I suffer with substance use disorder, major depressive disorder, and severe anxiety disorder. I want to share a bit of my story in hopes to raise more awareness, help others, and save as many lives as I can from this horrible disease of addiction. I have always struggled with some specific components that kind of led to addiction. Those things are overthinking, overanalyzing situations, minor problems people have every day, making them bigger than they need to be, which in turn leads to very extreme anxiety. I've also always been like a perfectionist, wanting things to be very close to perfect. And if they're not, having like an extremely hard time understanding why they're not or what's wrong with me, and then wondering, basically picking myself apart like negatively to the point of like isolation and major depression. And that can last 2 weeks to 2 months sometimes. So that's a little bit of about like myself and some of the things that I struggle with that kind of like had a big part in what led to addiction. So those are just kind of some of the things that led to it. My substance abuse really began to interfere with my daily life in about 2018. And that was also when I was about 3 years in to a very codependent, abusive relationship, both physically and mentally. So that also kind of, intertwined and made the addiction even worse. It was a lot of toxicity going, and we were both using. So every day kind of began with horrible fights, using the substance, not eating, not having proper hygiene, having absolutely no structure to my days, very toxic, unhealthy, and the day basically revolved around obtaining the substance. That's what active daily use does to a person. Not to mention, you start losing friends, family, your vehicle, you start selling everything in your home to obtain that substance, sometimes even your home. So, and sadly, near the end of my active addiction, all of that happened to me. So I lost completely everything. And then for me, kind of near the end of my active addiction, I was still in that kind of abusive relationship, but it was about 6 years in now and still with the same toxic person and kind of the toxic environment. And then kind of at that point, I believe, like, in a sense, God stepped in and kind of the U.S. Marshals were surrounding my house with their guns out to arrest my significant other. He was wanted for many charges, which I'm in turn kind of led to his addiction, his using, his mental health problems, all his charges go back and kind of relate to that as well. So they came in, took him, arrested him. Later on that night, I called my mom and told her for the first time that I was addicted to heroin, not just pills, because she thought, I was on Vicodin for a really long time from my doctor for my migraines. So she just thought, I abused my pain pills, and then when I took too many, I bought them off the street. So she never knew. So I called her and was like, Mom, I'm actually addicted to heroin. And she didn't really know what to do. So she came all the way down from up here. At the time I lived in Milwaukee, drove all the way down, came to pick me up, and I told her I want to get clean. I don't want to live this way anymore. So she came to get me, and basically a whole entire week went by until I could find a behavioral health bed that was open. So I kind of withdrawed at home and went through all the stuff that they set up there, just at home. Then I went to Rogers, but Rogers and a lot of behavioral health hospitals, the average stay is about 5 to 7 days. It's not long enough to, it's basically enough time to detox physically off that substance. And also they were mentioning all the PHP, IOP. You absolutely need that because this did not work for me. My inpatient stay at Rogers did not work. The reasons for that, I believe, are because, a 5-day stay is just not long enough. You need a long time to get over all the things, all the components in the anxiety, depression, all the things that, went into me using the toxicity, my mental health disorder, all the things, the coping skills I need to learn and be addressed within my anxiety. All those things contribute to using, and that's not handled in that 5-day stay. So I kept going on to use, get clean, use, get clean. It's like a vicious cycle just to numb myself and deal with my depression and anxiety. So it just kept going on and on. And eventually, this tore my family apart, my children apart. They wanted to believe in me, but so many broken promises, not being present in their lives, the pain they endured, seeing someone they love unrecognizable to them now. So they, at that point, because it was use, get clean, and this went on for years, they just cut me off at that point. In hopes that that would, wake me up and say, okay, I don't have my mom, I don't have my children. Is that enough for her? Is she gonna stop? Is she done? And it did essentially for a little while. I was doing well. I was clean for almost 2 years. I was enrolled in college. I had a nice home, my dogs, everything was really, really good. And going forward, I kind of was in another relationship at my job, and I lost my job for that reason. So I went into a depression again in isolation. I did remain clean and sober. However, I was just isolating. After I lost a job, I was in my room probably 3 months and never came out of it. So one day I went to take my daughter back home to her father's house and drove through an area that's very triggering for me. And I did relapse. And that evening when I relapsed, my mom could tell I was using, so she called the police. Well, I told her I wanted to go back to a behavioral health hospital and get help again, but in Washington County, when she called, the ambulance came and the police came, and then I ended up getting a charge and going to jail. So because, I was in jail before prior one time, but this time when I was in jail, I kind of focused, because I had that really long period of clean time, I kind of focused on the things in my anxiety, depression that need attention in order to heal me fully so that recovery can work for me. That's kind of what I focused on every day in jail this time. And some of those things that I realized I needed attention with was obsessing over trivial things that other people probably barely notice. Consumed by every mistake I make and beating myself up over it, knowing I'm capable of anything but not fully believing in myself. And then in most situations, the worst scenario was always my biggest thought. So those were things like I knew I needed to take care of in my recovery to be successful. And that's what I needed help with. So that's what I focused on while I was in jail. Also, like things I can't control, not like letting them get to me and stuff like that. So I thought to myself, the only way I'm going to get through this and be successful in recovery this time is to stay positive, use my coping skills and strategies I've learned in therapy previously, talk to my higher power, and most importantly, believe in myself. So I had fallen down again, and I had to get right back up and keep going and remember that I'm bigger than this disease of addiction, and that I can overcome my mental health, anxiety, and I can do it out of jail and sober. I did these things every day for 2 months. Every single day I focused on them, I wrote them down, I prayed, and I think it worked because I was offered drug treatment court in Washington County instead of going to prison. I believe that is a very good option, because it does help. Unlike the recovery attempts in my past, from the very beginning, I was treated like a person who was struggling and sad inside, who needed help, versus being treated like a horrible criminal junkie who deserved nothing out of life. I will tell you firsthand, this program is absolutely amazing and no doubt a better option than jail or prison for an addict, alcoholic, or anyone that suffers from mental health disorders. Drug treatment court, along with Alaris and Elevate, have given me the opportunity and the adequate time needed to heal and transform back into the person I'm really meant to be. Drug treatment court, Alaris, Elevate, they offer individual group therapy, AODA counseling, alumni, accountability, not being, and the most important is that you're seen. You're seen as the person you are, not just as another addict or a problem. They see you, not just your addiction. They see the light in each and every one of us and encourage us to shine to the fullest extent. They cheer us on. When they know we are going through a hard time and let us know that we are in fact strong enough to get through this and get through this sober. I have overcome myself so many struggles already being in drug treatment court, such as setting boundaries with those I love, putting myself first, believing in myself, while at the same time understanding I can't be perfect at everything. Letting go of things I can't control, the overthinking, has extremely changed, changing my perspective to finding the good and the bad. And I now understand that I am not perfect, but I am good enough. I have repented, I have changed, I've grown, and I live my life in the present one day at a time. I now realize I have gained so much from the losses in my life. I've gained peace, healing, perspective, and a greater appreciation and gratitude for the experiences that have happened throughout my addiction. I am now inspired to keep pushing myself to help others who are suffering and help overcome the obstacles and barriers they face due to addiction and mental health, which is why I have enrolled in this very college and transferred my college degree here to take substance abuse counselor program here at Moraine Park. So I truly believe that, God brought me back from the brink of death to now help others escape the same hell, and that hell is addiction. I believe, to anyone suffering, please reach out for help because it's possible. I think recovery is possible. I've done it, and I think you can do it. And anyone suffering, you got this. And that's all I have. I don't know if there's any questions.
Thank you for sharing your story. Does anyone have any questions or comments for Lisa?
I love you, girl.
Awesome. All right. Well, that wraps up our week 3, The Power of Substance Use, for our fentanyl lecture series. The post-quiz QR code is up on the board here. Again, if you have a phone, if you haven't already, please scan this and just answer those few questions. We did also have to reschedule week 4, so that will be next week, back here, same place, same time, 6 to 7:30, and that week is going to be focusing on our response as a county and a community. So we'll have the judge from Drug Treatment Court talking, we'll have someone from Washington County Human Services, Celebrate Recovery, just really talking about our response and our solution to the fentanyl crisis, to substance use disorder. So again, that will be next week. I believe it's March 9th. Pete, is that correct? March 9th. Again, back here in this room from 6 to 7:30. That is all we have for you guys tonight. Thank you for joining us. And if you have any questions or comments, we'll stick around for a little bit. Thank you. Thank you.